So I am a general and bariatric surgeon with the University of Kansas Health System, and I'm thrilled to be joined today by my co-speakers, Dr. Courtney Younglove, who is an obstetrician and gynecologist who is now one of only 69 fellows of the Obesity Medicine Society throughout the United States and Canada. She now practices full-time obesity medicine in the greater Kansas City area. And then also with us is Danielle Rudder, who's an APRN, also with the University of Kansas Health System at St. Francis campus in Topeka. So Danielle is also an obesity medicine specialist in the weight loss clinic there at the St. Francis Clinic. And she also is a fifth-generation breast cancer survivor. So she brings a lot of experience and a lot of knowledge there. So today we'd like to go over a couple of case presentations. And so our first case is going to be a 55-year-old postmenopausal female with a BMI of 55, who, ladies, are referred to your clinics. Last year, the patient was diagnosed with a left upper outer quadrant invasive ductal carcinoma, 1.2 centimeters, strongly hormone positive, HER2 negative, lymph node negative, but with a high Oncotype DX recurrence score. She underwent left lumpectomy and negative sentinel lymph node biopsy, followed by both adjuvant chemotherapy and radiation therapy, and she's now starting endocrine therapy with Arimidex. She does have a significant past history of nephrolithiasis, has required lithotripsy on 3 occasions, has passed stones spontaneously on others, obstructive sleep apnea on CPAP, and prediabetes. So she's now referred to the weight management for discussion of cancer risk reduction. And really, she said she didn't even know that weight played a role in cancer. But she does know that throughout her treatment, she gained 20 pounds over the course of treatment and is really concerned about starting her Arimidex, as she's heard that it can also lead to weight gain. So as we go through our topics today, we're hoping that we can kind of clear up obesity-associated cancer risk, discuss the weight gain associated with chemotherapy and endocrine therapy, go over what options would be available to this patient, and how do you decide even where to start. Go over activity recommendations, work through a patient weight loss scenario, and then even surgical treatment options. And we have limited time, so we're going to cover a lot of great facts quickly. So Dr. Younglove, if we go back to our patient here, what do you tell her about obesity and risks of cancer?
So we definitely know that there's a higher risk of developing breast cancer, especially postmenopausal breast cancer in women that have overweight or obesity. And those women have worse disease outcomes. They have a lower survival rate and a higher risk of recurrence, even when they're treated appropriately and they have disease regression. We also know that women with obesity or overweight have a higher risk of complications related to their surgery, radiation and chemotherapy. The therapies are often less effective, even when they're dosed appropriately for body weight. And the good thing is we know that postmenopausal weight loss lowers the risk, right? So the greater the loss, the lower the risk, even if we have some weight regain. So it definitely plays a huge role in cancer. Why? Why is obesity associated with cancer? There are a lot of reasons. This I could talk about forever, but we don't need to go down that rabbit hole, but they're very, very specific. They do have to do with inflammatory production. They promote gene mutations, angiogenesis, mitochondrial stress. I mean, cancer and obesity do go together very, very well. The other interesting thing is that growth of adipocytes and adipose tissue beyond the vascular supply creates cellular hypoxia, right? And when we have cellular hypoxia, we get increased immune and angiogenic responses, which accelerate the growth and the response of cancer. So a huge association there. As far as weight gain during treatment or after treatment, there are definitely mechanisms that people are going to have weight gain during cancer treatment. Some of it is simply edema and lymphedema, which is not obviously body mass in terms of adipose tissue, but women often have increased hunger, especially when they're on systemic steroids. They definitely have increased hunger with the nausea, and a lot of times when you have nausea, you get relief by eating. And when you're eating things, it's not usually broccoli to make the nausea better. It's usually some very simple carbohydrates, which we know are associated with higher weight gain. A lot of fatigue during cancer treatment. Women don't want to move, not even just exercise, but they don't want to move as much, which contributes to a lower basal metabolic rate. Most of these women are going to go through some sort of chemical or surgical menopause, which changes everything, and we could talk about that forever. But when you knock out a woman's hormones, everything changes, especially with insulin resistance, and we have to appreciate that. And then stress. I mean, obviously, when you're dealing with a cancer diagnosis and cancer treatment, you have a lot of stress, and a lot of people use eating as a coping mechanism for stress. We see that all the time. And sadly, even though we know this, that weight gain during chemotherapy has a lower chance of recovery. So we want to minimize that. And that's just the way it is. Now, things we need to consider. So let's say this patient comes to my clinic after a treatment's over. What do we need to think about? Obesity is associated with a higher rate of type 2 diabetes. We know she has prediabetes, so we need to definitely keep that in mind. Obesity is also associated with a very high risk of non-alcoholic fatty liver disease and dyslipidemia. So things that we need to consider independent of her weight. If we don't treat her prediabetes, she has a very high risk of developing type 2 diabetes. And that's really, really important. I screen all of our patients for NAFLD because it's so prevalent in our population. And does she meet criteria for metabolic syndrome? That seems to get missed sometimes. But once we have metabolic syndrome, we have a much higher risk of coronary artery disease and stroke. So she probably has central obesity. I don't have her measurements, but with a BMI in the 50s, she probably has central obesity. If she has high triglycerides, hypertension, low HDL, and we know she has hyperglycemia with her prediabetes, we need to keep that in mind. When you start looking at what are the treatment goals in an obesity medicine clinic, to attain a healthy body weight is great, but also what we also want to do is reduce her hyperinsulinemia, because that's a big problem with the prediabetes. Lifestyle measures are never contraindicated. We always need to put those in place. As far as dietary therapies that I would put in place for somebody with a history of cancer here, especially in somebody with prediabetes, a low glycemic dietary pattern, that helps with hyperinsulinemia. Treat her prediabetes. It usually also helps significantly with weight loss. I always talk to my patients about eliminating cancer-promoting or carcinogenic foods. We know processed meats are carcinogenic. Sugar and high fructose corn syrup are also carcinogenic. And really promote healthful foods. And we talk all the time about whole foods, but many whole foods actually will decrease the risk of cancer simply because of all the polyphenols and all the things within the foods that you're not getting in a lot of the supplements. The fiber is also very, very helpful. So citrus fruits and vegetables and legumes and nuts and some coffees and teas are usually pretty fantastic for lowering cancer recurrence and cancer incidence. And then not doing high cooking, high meats, because that's also carcinogenic. So just talking about those things in terms of cancer risk reduction and obesity treatment. Reduction of alcohol. My patients are always surprised by this, but too much alcohol is associated with breast cancer. I mean, it's there. We know that data. Don't know why people aren't hearing it, but we do talk about that. We always talk comprehensive lifestyle. We talk about other lifestyle measures, right? It's not just about how much are you eating or what are you eating, it's sleep, right? We know that diminished sleep and poor quality sleep is associated with obesity, independent of food intake, independent of caloric intake. So we talk to our patients about sleep, and the problem is she could have worse sleep based on her Arimidex, right? So that probably needs to be taken care of or at least addressed. And then stress. We also know that chronic stress is weight positive. It is. Acute stress can be weight negative, but chronic stress is weight positive. We elevate our cortisol, we elevate our insulin, we elevate our ghrelin. And she probably has increased stress, right? She just got treated for cancer, and now she's trying to put her life back together. I imagine if she wasn't on prophylactic therapy, she probably would have more stress, but I don't know. But we do need to talk about how do you reduce chronic stress. If you really want to help with weight and help with cancer recurrence, you kind of have to put it together as the whole lifestyle does matter. And where do you start? So we have a multitude of anti-obesity medications that we use in our clinic that people are using all over the place. These are the current FDA-approved anti-obesity medications. Not all of them are good tools for every patient. And in a vacuum, they're very rarely effective. So if you just give somebody an anti-obesity medication and do not institute lifestyle measures, you're going to see a small amount of weight loss and then a plateau and then a weight regain. So I'd never recommend using those as the primary treatment. And I don't know all of this woman's comorbidities, so obviously I can't go through and tell you which one I would use for her. We definitely have different obesity phenotypes, and we tend to use drugs into the right phenotype. But then we also have a list of what can't you use, even if it's the right phenotype. We know bupropion can't be used in somebody that's on tamoxifen. It lowers the effectiveness of tamoxifen, but that's not applicable when they're on Arimidex, so that's good that she's on Arimidex because that opens that up. Topiramate is a nice little medication, not by itself, but It helps with other medications, but we cannot use that in her because of her history of nephrolithiasis. That definitely increases the risk of that, and we wouldn't want to do that to this woman. I am very liberal with use of glucophage, especially in somebody with prediabetes. I would start that right away. That would be one of the very first conversations I would have with her. And even if she didn't have prediabetes with a BMI that high, it would probably help lower insulin resistance, which would help us with our weight loss. And again, there's lots of other comorbidities that we would have to go through and decide what is the right treatment if she's a candidate for an AOM. It's hard to say. As far as activity recommendations, any type of activity is better than none, right? A little bit is better than none, and a lot is better than a little bit. Sedentary lifestyle increases the risk of developing breast cancer. It lowers the risk of breast cancer to be active, right? Physical activity doesn't actually cause weight loss. It'll cause secondary weight loss by lowering insulin resistance, and it will cause visceral fat reduction and huge health benefits, but we don't talk with our patients very much about this will help you lose weight. It just helps you be a healthier whole person, and it makes it a harder environment for cancer to actually thrive. So activity is a huge thing. And then, there we go.
So thank you, Dr. Younglove. That was a tremendous amount of information all in a nutshell there. That was fantastic. And, you know, oftentimes in our obesity medicine meetings and conferences that we go to, you know, they'll show us a patient and then take us through their journey and see their weight loss, if they had weight regain, when you implement different treatments. But very rarely do we have anyone who can give us the personal insights of their own life and their journey. But Danielle's going to do that for us here this morning.
So this is my personal breast cancer story and my obesity story because they do go hand in hand here. So the picture on the left there is my grandma, myself on my wedding day, my mom, and then my sister, and all four of us are breast cancer survivors. So yeah, and then the other picture is my sister and myself in December of 2016 after I had finished my chemo and was in the middle of radiation. My sister was in the middle of her chemo treatments there. And there's actually a picture, a bigger picture of her husband, my husband, her, and then myself, and all four of us are bald. My husband is bald all the time, her husband is not. But it's a cute picture. But you can see that we obviously both going through the same thing here. So my breast cancer story is interesting because I'm not the typical patient. I was 36 when I was diagnosed. I knew I was going to have breast cancer eventually just based on my family history. I did not expect to be 36. My mom had just turned 50. My grandmother was in her 80s. My great-grandmother was in her 60s. My great-aunt was in her 40s, and I'm not 100% sure what my great-great-grandmother, how old she was. So I expected to be a little bit older, but here I was at 36. But knowing my family history, I was diligent about doing my self-breast exams. And so when I found my lumps in April of 2016, I scheduled an appointment with my OBGYN's office, and I went in, and the nurse midwife there, she was able to feel the lumps that I could feel, but she was also able to feel an additional lump there. We were also able to express some fluid from my left nipple, which we sent to cytology. And she set me up with a mammogram and an ultrasound within 10 days of seeing her. She called me the night before my mammogram ultrasound appointment and said, Danielle, they found some abnormal cells on your slide, but they don't know what they are or what's, you know, what the significance is of them. So she said she ordered a ductogram to go along with my ultrasound and mammogram, and that was set up for the next morning. So my husband accompanied me to my mammogram ultrasound appointment, and I did my mammogram. I did a 3D mammogram, and I did an ultrasound. But you have to remember that my breasts were a size 42 double G. I had extremely large breasts, and I was young, so I had extremely dense breast. So the radiologist looked at my mammogram and my ultrasound, and he said, she's fine, go home. And so the tech comes in and tells me to go home. And I'm like, but what about the weird cells, and aren't I supposed to have a ductogram? So she leaves the room again, goes to talk to the radiologist, and he says, no, everything looks good, go home. So I walked out, told my husband, I said, hey, everything looks good, let's go home. You know, like this big sigh of relief. So I was set up with my OBGYN's office, the nurse practitioner that I normally see for my yearly stuff. I went in and I said, Cheryl, this was the next week. I said, Cheryl, this just isn't sitting well with me. I know my family history. And I said, I can feel these lumps. I would just like to have a biopsy. And she said, you know what, it doesn't sit well with me either. Let's go ahead and get you set up with a surgeon. So she sent me to Dr. McAllaster's partner, Dr. Hu, and Dr. Sydney, who did a biopsy in June of 2016. So we had some delay there. And I remember the date that Dr. Hu walked in the office and told me I had DCIS, because it was my mom and dad's anniversary. So I won't ever forget that date. And I remember her walking in and saying, Danielle, you have cancer. I'm sorry, I get a little emotional here. And then she looks at me and she goes, but wait, you had other lumps that we didn't biopsy? And I said, yeah, I did. And she said, let's set you up for a breast MRI and let's see what's going on. And so I had a breast MRI within a few days of that, and sure enough, I had DCIS and left breast in the upper quadrant on the out. But I also had a little bit of a lymph node that kind of came up as well, that showed that I had, you know, breast cancer possibly there as well. And so we set it up for me to have, well, initially it was supposed to be a lumpectomy, and I eventually told her, I said, no way, I know my family history. We are doing a bilateral mastectomy. Doctor who was like, go home, talk to your husband about this. This is a big decision. And I looked at her and said, there's no decision to be made. You know, I know. And literally, as I'm walking out of that office, my case manager for my insurance company calls me and says, you have a cancer diagnosis. And I'm like, that's weird, but yes, I do. And I told her my family history, and I said, I'm doing a bilateral mastectomy. And she said, it's approved. And so the surgeon's office didn't even have to call to get approval because I had already done it. But so I went home and told my husband, and of course he agreed with me. So when I had my bilateral mastectomy, my mom and dad came, as well as my older sister. And we were talking right before they took me back to surgery. And my sister said, well, I just had my 3D mammogram in June. And she said, everything looks good. And I looked at her and I said, Rochelle, I had a mammogram and they didn't find it. I said, they found it on the MRI. And she goes, huh, I wonder if I need to go home and have an MRI as a baseline. And I said, I think you do. And so after she left, she went home and she talked to her OBGYN, and her OBGYN went ahead and ordered that for her. And sure enough, my sister had ductal carcinoma in both breasts. And that was September 2016 when we found that out. So obviously both of us going through cancer treatments at the same time. It was very stressful in our family. But we both made it through. We're both here. You know, we're both doing well, which is great. So segueing into my obesity struggle. So the struggle is real. So in July of 2008, I actually had bariatric surgery. That's my pre-surgery picture. I weighed 333 pounds. In November 2009, when that picture was taken, that was my 30th birthday. I was a little under 200 pounds at that point, so I'd lost over 130 pounds. And then that lower right picture is after my cancer treatments, and you can see I gained back a significant amount of weight there, and then after starting medical weight loss that December of 2018. So my weight struggles have been really, truly all of my life. I started around that preteen, you know, starting that puberty. I had PCOS, but it went undiagnosed because my family practitioner chalked my weight gain up to genetics. Because my dad's a big guy. He's 360 pounds, he's 6'5". His entire family struggles with severe obesity, and I mean severe obesity. And so he's like, oh, you're just gonna take after that side of your family. So he didn't really bother to figure out, you know, my whole story of why I was gaining weight. So I gained through my teenage years, I gained through my early 20s. When I was 25, I literally had a nurse practitioner come in, hand me a pamphlet about PCOS, told me she thought I had it, and then she walked out of the room without doing a damn thing about it. So no treatment, no testing, no nothing. I still didn't know I had PCOS. So I continued to gain. And you guys know PCOS, the worse you weigh, the worse the PCOS is, the worse the PCOS is, the more you're gonna gain, right? It's a snowball effect. So by the time I was 28, I had gotten married. My husband and I were trying to start our family, and I couldn't get pregnant, and we didn't know why. But I had worked with a physician and another nurse at the hospital, and both of them lost significant amounts of weight, and both of them got pregnant like that. And I thought, well, gosh, maybe it's my weight that's causing the issues. And so I had the lap band surgery with another one of Jen's partners, Dr. James Hamilton, in July of 2008. I lost that 130 pounds. I maintained it for a couple years, and then I did get pregnant with my oldest son. And while I did well for the first half of my pregnancy, that second half of my pregnancy, I had preeclampsia symptoms, and I eventually landed on bed rest for the last 2 months of my pregnancy. I gained 80 pounds during that time because I went from having a lot of movement. I was at the gym 4 days a week, 3, 4, 5 hours, and to get that weight off and keep it off. But, you know, so having zero activity then. And my husband's disabled, so he doesn't cook. So breakfast, lunch, and dinner became takeout. And baby wants what baby wants, right? So here I was. But everybody kept telling me, oh, it's baby weight. It'll come off when, you know, you have that baby, or, you know, it's water weight from the preeclampsia stuff. It'll come off. Yeah, I'm not that lucky. So even though I breastfed for an entire year, I didn't lose a single pound. I did the yo-yo thing between my 2 boys. I had hyperemesis with my second pregnancy, so I didn't gain anything, but I wanted to eat everything under the sun after I had him. So I spent the next year, you know, breastfeeding him and eating whatever. Again, I didn't lose any weight with breastfeeding, so I was eventually back up that 80 pounds. Dr. Hamilton adjusted my lap band shortly after that. I maintained for a little bit. I lost about 40 pounds, and I maintained that for a little bit. I started my master's program in November of 2015. I also changed jobs. I was working hospice by that point. I came back to St. Francis campus, and I took a job as a triage nurse. So basically, I was the ask a nurse, and I sat in my office all day, 8 to 5, Monday through Friday, and didn't really get up. And so very sedentary. I'd go home and be mom for a little bit, and then I would be up late at night for my master's program, and I was eating to keep myself awake, right? So watch the scale come up, and I beat it back down, come back up, beat it back down. In June of 2016 is when my world shattered. It was the middle of my master's program. I had a 2-year-old and a 5-year-old at home. I have a disabled husband. I'm the full-time breadwinner, so I already have a lot on my plate. So that cancer diagnosis was devastating. So I started binge eating to deal with my stress. Crazy amounts of food late at night. You know, I'm doing my homework, not only help keep myself awake, but to just cope with some of that stress. In a weird turn of events, I saw radiology oncology before I saw oncology. My rad onc told me to exercise through chemo. Best advice I ever received about cancer treatments was exercise. So I started swimming and doing an aqua aerobics class for about an hour, 5 to 7 days a week. But I'm gonna tell you, you cannot outrun a bad diet, okay? So even with all of that activity, it wasn't any match for my binge eating, first of all. And then when I actually started chemo, I had steroids, that should say hormonal treatment and chemo. And then they put me in menopause at age 36. So here I go, my weight's starting to climb, and it's continuing to climb. Of course, then my sister's cancer diagnosis, more stress and more stress eating, right? So I had 3 months of chemo, 37 radiation treatments, and 6 surgeries in a two-year period. My body went through hell and back, you know. And when I was all said and done, my weight was well past the 80 pounds I'd gained with my kiddos. I brought it back down to about 80, 90 pound weight gain. And eventually made it back into Dr. Hamilton's office. But one of those appointments and things that fell in between that time was my survivorship appointment with oncology. And they discussed weight loss to help prevent recurrence, and then also that my aromatase inhibitor would work better if I lost weight. And so that was something that was stuck, you know, here that I needed to do. Of course, all of those surgeries and a total hysterectomy and all of that other stuff. I finally got a diagnosis of PCOS when I had my total hysterectomy, you know, but a little late at that point. So in May of 2018, I started my weight loss journey with medical weight loss, and I lost 60 pounds up until last year. I started having problems with my lap band, had that out, and I eventually had the gastric sleeve in November of last year. So now I'm back over having lost 100 pounds from my heaviest weight. So you guys all know this information, so the good news, the bad news, and of course it talks about weight here, but I did want to stop here. This was actually something that I told my cancer patients that I see personally, and of course, not everybody does a cancer survivorship appointment, and I would truly tell you to do that because it's going to normalize some of these things for them, and that's a huge thing, especially that weight gain, and knowing that. So totally recommend doing that if you're not doing that. Okay, so there's 5,000 reasons why people gain weight, of course, and I have a handful of them on there. And of course, we know that lifestyle changes are the foundation to any weight loss treatment. Courtney did a great job of talking about that. However, with obesity and pre-obesity, we're treating chemistry and not character. So this is where using people like Courtney and myself is very important. If you guys don't know where to start, find the people who do. You know, I love talking about my story, and I talk about my story with every single one of my patients because I want them to know that they're not alone in all of these struggles of what they've done for trying to lose weight. And they're, you know, but you wouldn't ask, you know, a patient with diabetes to treat their diabetes on their own. You're gonna make sure that they have education, you make sure they have tools and things to check that. So you need to do that. Consider obesity as a disease process and do that as well. Make sure that they have tools and education as well, okay? So, shared decision making. So what is it? It's a communication process between patients and clinicians to make sure that we are making clear and unbiased, you know, joint decisions with your patient. So, but things to consider with that. Obesity is a super touchy subject. You need to ask permission before you address the subject of obesity with your patients. You also need to check your weight biases at the door, because I can guarantee every patient that you see that has obesity has tried multiple things and failed, okay? And then talking about the why, coming back to that why do they need treatment? Why does this work better? This med work better than any other med? Why do you need obesity treatment for the rest of your life? So, you know, we want to make sure that we're treating it as a chronic and relapsing and multifactorial disease process, because that's exactly what it is. So, some ideas for that. I'm going to try to hurry so Jen can actually get into that.
All right, so in this patient who we discussed at first, and then also in Danielle's case, you know, is bariatric surgery an option for cancer risk reduction, and is it a proven option? So the Swedish Obese Subjects Study, this is one of the most quoted studies because it was the first long-term prospective controlled trial of bariatric surgery endpoints. And so it's now gone beyond 20 years. And so the primary endpoint was weight loss, and you can see there the surgical arm, over 20 years, they still lost 18% of total body weight, whereas the medical arm actually gained 1% of total body weight. Now, disclaimer, this study started in 1985, so we do not have all the medications that we have today, which are more and more successful all the time. But more importantly, the secondary outpoints that they came: decreased mortality in the surgical patients, decreased diabetes, cardiovascular disease, stroke, and cancer. So risk reduction there of over 42% in women. So we should really look at these. These aren't weight loss operations with bariatric surgery. They are metabolic operations. And so I'm going to go quickly through the rest of these slides here to kind of make sure we get done in time. But the question is, does it decrease cancer incidence after bariatric surgery? The answer is yes, and it increases it even more in those that are hormonally driven. So it can increase it anywhere from 33 up to 41%. It also, there are some variable data for colorectal surgery. So there are some smaller studies, that thought this may actually increase the risk of colorectal cancer, but that hasn't borne out in larger population-based studies. And in that SOS study that I mentioned, bariatric colorectal cases were fewer, and even more so in rectal cancer. And so the schematic there on the right, so again, this study started in 1985 in the SOS study. So if that, there were multiple different operations. So the gastric bypass, which we still perform today, was only 13% of those operations. The lap band, like Danielle mentioned, was 19%, which really we don't do much anymore. It's kind of fallen by the wayside.
You don't want to do it anymore either. The complications are miserable.
Yes, it's the lowest risk surgery at the time of the operation, but what we found over the years, it's the highest risk of needing revisions and potentially removed. And then the vertical banded gastroplasty, which isn't performed any longer as well. And so the question is it really just the weight loss, or is it surgery specific as well? And so this first study there listed by Khaled et al. Looked at weight management versus vertical sleeve gastrectomy versus gastric bypass. And this one interesting because this is more of our common state today, the vertical sleeve gastrectomy now being the most commonly offered operation, followed by the gastric bypass. And really variable data, but shows that both operations successful in decreasing weight, decreasing cancer risk. And then again, even more so in those that are hormonally driven. This is just a schematic of the operation. So the sleeve gastrectomy on the left, where we remove 75 to 80% of the stomach, it ends up looking like a long skinny banana. Next is the Roux-en-Y gastric bypass, a small proximal pouch. We reroute the small intestine. Next, which you'll probably begin to hear more and more of over the next decade, is the biliopancreatic diversion with duodenal switch. This operation actually is where the sleeve came about. This used to be a two-stage operation in very high BMI patients. They'd do the sleeve, let them lose significant weight, and come back when it was safer to do the second stage, which is a much more aggressive bypass. And then finally, a single anastomosis duodenal switch at the end. Again, as our sleeve patients get further and further out, they may need these procedures, which could be revisional of those last two. Lap band just for a picture to show, and there are endoscopic methods of weight loss as well. So that's a picture of the endoscopic sleeve gastroplasty on the bottom. So those are done through an endoscope through the mouth, where the stomach is actually plicated or quilted in layers with sutures. Ends up looking similar to the sleeve gastrectomy, but has different hormonal mechanisms. And then the intragastric balloon, where a balloon is delivered deflated into the stomach at first, and then it's inflated. It's a space-occupying lesion. Temporary, stays in from 3 months to 6 months, and then the balloon is removed. So those are the operations. These are the success rates. And so we know that the BPD has the highest associated weight loss, with patients losing 70 to 80% of their excess body weight. Gastric bypass, 60 to 65, the sleeve 55 to 60, and then finally the band. But the risk of surgery going along with those as well. The BPD-DS having higher risk, and then lower as we get down there. So the benefits of bariatric surgery, again, we mentioned all the metabolic complications, and that really these are metabolic operations. This is not a disease of excess weight, it's a disease of excess adipose tissue, and it's the metabolic consequences of that excess adipose tissue. And why is bariatric surgery important? Because obesity is a chronic and difficult to treat disease. And once patients are obese and their BMI has above 30, which is the definition of obesity, it is extremely rare that they'll get down to what we would call a healthy BMI, or that under 25. So a BMI above 30, less than 1 in 210 men will get down to that BMI goal, less than 1 in 124 women, and those odds are even less as someone's weight increases. So a BMI above 40, you see now men less than a 0.07% chance of attaining that, and women 0.1% chance. So it's very difficult. And why is it difficult? It should be simple, right? Calories in versus calorie out? No.
No.
And that's what we all need to get away of. And sadly, obesity is still a disease that is stigmatized again. We see it as potentially laziness. And even it wasn't until 2013 that the AMA labeled obesity as a disease. And in that consistent statement, there were still people who were opposed to being listed as a disease. So it should be simple. Calories in, calories out, not so much. This is a schematic here of why this is not so simple. This is the physiology of hunger. And so on the left-hand side, we have homeostatic hunger, right? So our body should have mechanisms to tell our brain when we need nutrition, and it should have mechanisms to tell our brain when we have enough nutrition and turn it off. But then comes into play the right side, the hedonic hunger, right? And so this is increased food availability. Went to the restroom, wasn't all that hungry, but I saw that snack pack. You better bet that's in my purse for after this talk. We have emotional eating, social factors, reward, pleasure. Functional brain imaging has showed those reward pleasure sensors are more active and overactive in obese patients compared to healthy weight individuals. And then sensory cues. So it's very complex. So last thing I want to cover here, surgical mechanisms of weight loss. So these are why these work. So if we look, the left hand's the gastric bypass, the right hand's the sleeve gastrectomy. These are the gut hormonal changes that happen as a consequence of the operation. You know, we used to say, well, we made the stomach smaller, you could take less in, we bypass, so you malabsorb some. Really not the case. Part of it, but it's not this whole picture. So you can see on both, there's calorie restriction. There is some difference in taste, smell, food choices. Big one, ghrelin. So ghrelin is the main hunger stimulating hormone that's made in the periphery of the body. The majority of that is made in the fundus of the stomach, which we take out with the sleeve gastrectomy. So you see significant decreases in ghrelin. You see a decrease in gastric bypass as well. We have more bile acid secretion, which also plays a role. We see a change in the gut bacteria of the colon as a result of the bariatric operations. And there's different gut bacteria in lean patients compared to obese patients. And you see the whole list here. Now, everyone brace yourself, because this is where we're going to show our bodies are so mean-spirited when it comes to weight regain, right? So that top diagram there is diet. So when we diet and we lose weight with diet and exercise, this is what our body does hormonally. Because evolutionarily, we want those extra weight stores, right? We wanted those times in feast or in times of famine. And so when we lose that weight, our body tries to set us back up to our prior set point. So we increase ghrelin, the hunger stimulating hormone. We decrease our GLP-1, which helps with insulin sensitivity. We decrease our bile acids. Hunger goes up. Our fat stores go down and says you need to eat more, and it pushes our weight back up. And if you look at the bariatric surgical procedures, the reason they're effective, they do the exact opposite. So patients need to get in healthy nutrition, they need to get in healthy proteins, but it allows us to take in much fewer calories while our gut and our brain still thinks that we're in a well-fed state. So who qualifies for bariatric surgery? So in general, these are their insurance criteria for surgery, but a BMI above 40, which is on average is about 100 pounds overweight, or a BMI above 35 if a patient has those obesity-related comorbidities, which are listed there. We do want patients to have tried other efforts in the past. We don't want them to have surgery unless it's a tool that they need. And more importantly, and sadly really, is that not all insurance cover bariatric procedures. Most bariatric programs do have a cash pay option for those that don't cover, but it's something that we continue to advocate for. So going back to our patient, absolutely, she would be a great candidate for bariatric surgery. But the more important thing is that it really should not be a decision of bariatric surgery versus medical treatment. What we know, obesity is a difficult and chronic disease. And so these patients need all the tools that we have in our armamentarium. It may mean they need weight loss, and if that's successful for them long term, that's great. Sometimes we have to reach out for help and get patients down to a healthier weight with medical weight loss so that they can do a bariatric operation in a more safe fashion. And very frequently, almost always, we send patients afterwards to have long-term care with our medical weight loss colleagues, because it's just not just the option, it's food, it's nutrition, it's psychology, it's behavior, and it's everything to have a healthy lifestyle. So it's not just one or the other. Really, it does take a team effort. All right, we have, take a breath every time for questions. Thank you, yeah.
I think in light of time, there are a couple questions, but we'd maybe ask our experts to go on the app and answer those questions. One's about cancer, sugar-feeding cancer, and then the other has to do with different types of diet like keto and stuff. So go to the app and read the answers, because you may have those questions as well. So thank you to our panel, and we'll bring the next presenter.